request Dr. Saravanan, Senior Consultant, HOD of Retina Department, Aravind Coimbatore. He will be talking on managing retinal detachment with cataract and integrated approach.
Thanks, Harshali, for the invitation. So this is not a slides, please. The occurrence of both combined cataract and retinal detachment is not that very common compared to other macular disorders like ERM, macular hole, vitreomacular attraction, and diabetic macular edema. So a little bit uncommon compared to these more common conditions. So when you talk about RD, you have two sort of exudative RD. Usually don't manage with the surgery. It's usually trying to treat the cause of exudative RD, mostly involves medical therapy. But more commonly, what we see is the rheumatologic retinal detachment as well as the traction retinal detachment. So when you have a combined cataract and RD, then it becomes a choice of what to do first, what to do second, or whether to do both. Depending upon the media clarity, I usually try to prefer to do the retina procedure first, as long as the media clarity will allow me to do it. Sometimes even in the presence of posterior subcapsular cataract, if it is not that very dense, I can try to view the retina to a little bit of off center to a peripheral clearer areas and address it, especially in both TRDs as well as RDs. If it is possible, my first choice is always to do the retinal surgery first and then keep the cataract surgery for the second phase, because most of the times we fill it with the oil and we can combine the cataract surgery along with the oil removal. Because in the olden days, if we look at we were always facing out, probably we come from the old school, that time scleral buckling was the first choice for any rheumatologic retinal detachment. And that time there was no, when I was starting to do my surgery, there was no SICS or phaco, most of the all ECC patients. And all the time what happens is that when you do surgery, if you have a ECC wound, it will definitely open up during the buckling surgery, and it makes a mess. Once the eye collapses, a lot of pigment dispersion, and it becomes doubly difficult to visualize the posterior segment, especially through indirect ophthalmoscope, and it makes surgery very, very difficult. So during the buckle era, our choice was always to do the buckling first, and because even if properly sutured, scleral buckling becomes a big issue when you are doing in these cases. But this changed a lot once we had SACS and phaco coming up, and now we are a little bit more comfortable doing combined surgeries compared to the older generation. So when you're treating both together, some of the issues which you face is that wound integrity, as I was talking about. Even in SACS, sometimes the eye can collapse. Phaco also, you can put sutures in case the wound is not that very stiff. So again, immediately post-operative, because these patients can have a little bit more dense cataract sometimes because of the high hypotony, you may have issues during the cataract surgery. The immediate, before we shift to the retina theatre, the occurrence of corneal edema becomes an issue, which can be dealt with peeling the epithelium or using topical glycerin. But more the issue is that when you have a pigment dispersion or bleeding, so usually in these eyes, I fill up the anterior chamber with visco till I finish the surgery, because once the pigment starts dispersing, it keeps on coming. How many times you wash, it keeps on coming up again and again during the surgery. So better to fill it up with visco before you proceed, and remove the visco after you finish your retinal procedure. So sometimes you have pupillary constriction, like I showed in the previous photograph. You can use iris hooks. Sometimes you also do iridectomy to sort of enlarge the pupil, especially in patients who have got concomitant significant uveitis with Sine K. And longer time, sometimes it can be issue for the patient, because combining, especially in our hospital, we don't do the same person does not do the cataract and the retina, so it becomes an issue when you're dealing with both. And in case you are doing general anesthesia, both has to be done on the same table, so you need a single surgeon to do that. Machine should be available in the same theater. So advantage is that reduced mobility, finishes off in single surgery, and in case of dense cataract, you can clear up the media so that you can do the retina surgery in a proper way. And one more issue is that when you are doing the peripheral vitreous base shaving, you're always afraid of touching the lens, and we have IOL or FAK inside, we are not bothered too much. As I told you, whether it's good to do surgery should be done with the same person or a different person. So ideally, if both surgeries can be done by a single surgeon, doing both cataract and retina, the surgical time and shifting theaters is lesser. But in case you are not, like I'm not a phaco surgeon, but I have to use my next theater colleague to do this. So then the time also becomes issue, and shifting theater also becomes an issue. Then we have what you have here is the as I told you, all this whole thing changed during MIVS era, and now we don't have to suture. So, and also the surgical intervention also becomes easier. So even if you have a freshly operated wound, it becomes much more simpler to operate on these eyes. So after the both the phaco and MIVS, things have considerably become comfortable when you're combining both the steps. So the next question comes where should we put the incisions? Actually, look at the three ports. First, you assume where you want to make your ports, and better not to make your SICS or your phaco incision along the axis of the ports. If you can make it in between these ports, then the chance of the wound opening up intraoperatively and the chance of intraoperative hypotony or iris prolapse all becomes lesser. So try to make your wounds away from your not in the axis of the sclerotype ports. In case if the wound is not very tight and it's leaking, always don't hesitate to put a suture. It makes my life much more simpler for the retina surgeon who is going to take up for the main step surgery later on. In case the cornea is edematous, you can always peel the epithelium, or if you want to preserve the epithelium in diabetic patients, you can use topical glycerin to make it better. And one more issue is that when you cut off the PC in patients with pseudophakia, you can have air sort of condensing, water vapor condensing when you are doing a fluid exchange. This can be addressed by coating the posterior surface of the IOL with a little bit of visco. That will help you to address that also. And whether to put the IOL in the first step or not, especially when you're doing the recommendation RD, because there is a decrease in the axial length because of the anterior movement of the retina, the axial length calculation, the power calculation becomes an issue. So in case where the bullous retinal attachment, always keep the IOL surgery for the second step, or if we can make the surgery patient aphakic and then do the IOL implantation during the SOR procedure. Again, the choice of tamponade, especially when you're combining, I feel always silicone oil is better because gas is more inflammatory, and not only that, as Sharath already pointed out, the optic capture IOL tends to move forward with Syneque, and optic capture is much more common with gas. So I usually prefer silicone oil because it's a little bit more protected towards the postoperative inflammation part. And as regards to diabetic retinopathy with TRD, I always again prefer to phase it out. My first choice is never to do them together unless there are significant other comorbidities. Reason is that the surgery in a diabetic retinopathy is much more prolonged, and where we have to keep the IOP high because of the bleeding part, and the cornea usually becomes severely edematous towards the end of the surgery. So I always prefer to at least give a gap of 1 to 2 weeks, if it is affordable, to phase out the cataract and the retina surgery. So what we do is first we do the phaco surgery and give a sort of injection at the end of the procedure, to Avastin injection. So it also helps to shrink out the new vessels so that the next surgery, the bleeding, intraoperative bleeding is much lesser. And as regards the choice of IOL, I think the coming speaker also will talk about that. So one last slide is that suppose you are a cataract surgeon who is operating on an already vitrectomized eye. So always be aware that always consider this as a PPC case. Even though the VR surgeon may not tell that he had a lens touch intraoperatively, always assume that there's a lens touch and the PC is weak. So because in case you are operating and you don't take appropriate care to limit your hydrodissection and all those things, you may get a nucleus drop, and especially because there's no vitreous to protect you, the lens will immediately sink down into the posterior vitreous cavity. So any vitrectomized eye, consider like a PPC and do the surgery. Don't assume that it is a good surgery done by the. Always assume that the VR surgeon was a bad person. He's hiding the truth from you, that he had a lens touch and he's not telling you. Assume that way and then carry on with the surgery. I'll stop here. Thank you for your attention.
Thank you, Dr. Saravanan. So, one doubt, do we treat any lattice degenerations or holes pre-operatively?
I don't take a special care as regards to both the LASIK as well as cataract surgery. Unless you are expecting a PC rent intraoperative, like a PPC, where you expect a PC rent and vitreous disturbance, in those cases you can do a preoperative barrage laser. But both in LASIK as well as routine cataract surgery, where you don't expect a high risk of PC compromise, I don't advise unless there are other RD, family history of RD, symptomatic floaters and flashes. So unless there is other risk factors, I don't give special consideration for a routine cataract surgery. In case there's a PPC where you have high risk of PC disturbance, then you can do to prevent that actually.
Even for the atrophic holes?
Atrophic holes I don't do. If it's a tear, like I don't change, alter from my routine recommendations what you do for routine. Like suppose the patient is coming with intact lens and clear lens, what's your recommendation? I just follow that for a cataract unless there is significant risk.